Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show, bringing you another awesome guest today involved in creating a better tomorrow for many people out there. Today, we have the honor of being joined by Dr. Stephen Landers, who is the president and chief executive officer of Hebrew SeniorLife, which is a nonprofit Harvard Medical School affiliated center offering senior living communities and senior healthcare services for older adults throughout the Boston metropolitan area. They're also actively involved in conducting aging research, focused on improving the way that we grow older, as well as education for the next generation of healthcare providers and caregivers in this segment. Dr. Landers is a practicing physician. He's certified in family medicine, geriatric medicine, as well as both hospice and palliative care medicine. He is also a faculty member at Harvard Medical School and holds an appointment as clinical associate professor of medicine and community health at Rutgers Robert Wood Johnson Medical School. Prior to joining Hebrew SeniorLife, Dr. Landers, for over a decade, served as president and CEO of the Visiting Nurse Association Health Group, a multistate home health, hospice, and community health organization. And then he previously served as the director of the Center for Home Care and Community Rehabilitation and director of post-acute operations for the Cleveland Clinic. In 2014, he received the NJBiz 40 Under 40 Award, the recognition for New Jersey's most accomplished young business leader. Dr. Landers is a graduate of Case Western Reserve University School of Medicine and Johns Hopkins University School of Hygiene and Public Health, and he is a recognized leader and innovator in home health, primary care, and aging services, and really an outspoken advocate for nursing and the frontline workforce, as well as broadly improving care for older Americans. We're honored to have him with us today. A lot of really interesting themes to get into today. Dr. Stephen Landers, thank you so much for taking the time to come on our show.
Thanks for having me. What a generous introduction. So happy to get to speak.
Absolutely. It's I enjoy these themes, a lot of really important topics for our show, and looking forward to getting into them. But as we typically do, I love to start these episodes off by handing our guests the floor for a little bit, just to talk a little bit more about themselves in the early days. Stephen, if you could take us a little into you, a little of your background story, sort of everything from where you grew up to the development of your interest in public health and medicine, of course, geriatrics. I think that'd be a great way to get things started off.
Yeah, absolutely. I'm basically the luckiest person ever. I grew up in the Cleveland, Ohio area in a town called Shaker Heights, and my parents were very involved in healthcare and incredible leaders in many respects. My mom, an occupational therapist who became a hospital head of operations, and my dad, a family dentist who was very involved with teaching anatomy, physiology, and other aspects of health sciences. And so it was an incredibly rich environment for somebody that might become interested in healthcare and aging, because basically our dinner table conversation was about, kind of what's going on at the hospital, and how's various issues of health policy impacting the lives of my parents and their colleagues, and my folks. Also, to understand, very socially minded people that wanted to see their community have better services, that that care and care outcomes be more equitable and fair, and that there be relief of suffering, and that there be respect for the people doing the hard work on the front lines of care. And so that's the type of I got to do all the other fun stuff of growing up in a wonderful place. But in terms of my career, that had the most impact on me. And over time, like most younger folks, there are moments of rebellion and maybe not necessarily following every aspect of my parents' recommendations, but ultimately saw them as my heroes, people to look up to. And I followed a path in many ways similar to what they cared about. And it's been just an awesome opportunity. I ended up going, as you said, to medical school and got into family medicine. Really, the way I saw it was that a lot, again, based on my parents' experiences, is that I didn't want to just be part of the system. I wanted a chance to be a part of how can we change? How can we, do more of the good stuff and do less of the stuff that's not working, and be part of, policies, institutional approaches to doing better, to improving quality, improving outcomes, improving the experience of care, making it better for the people doing the work. And so always along the way, both with my medical training and alongside that, some business and policy training, my focus on how could you pair these things to be in a place to try to, in some small way, make things better. Family medicine, I just saw it as just an incredible field, and then ultimately geriatrics as well, because it's so holistic, so focused on the whole person, family, their health in the community, all the different factors that drive human health beyond just, the labs and the medicines, but the sort of the psychosocial aspects of human health. And those fields are so focused and so rich and steeped in those different aspects that it just attracted me to want to be a part of it. And then, there's a lot there. I mean, I don't want to, drive you nuts with all the details of those opportunities. But the thing that really, really, really made a huge impact and helped me get to be involved in the cool stuff I'm doing now was that my first job after finishing my training as a family doctor was to start a physician house call or home visiting practice for low mobility older adults, and really mostly in high poverty neighborhoods in the Cleveland, Ohio area. And I did that with the support of the academic Case Western Reserve Department of Family Medicine, and really got to get out into the community, make thousands actually of home visits ultimately to low mobility shut-in elders, and learn about their circumstances, their family circumstances. Saw a lot of really beautiful things like families coming together and rallying and supporting each other at the worst moments, and all the great help that's out there in the community, home health aides and nurses, and even some cases, hospice care when needed. And then also some of the bad stuff, neglect, people, suffering with consequences of aging and poverty and other things that aren't as pretty. So that experience was very formative for me.
Yeah, that's a really interesting part, because I enjoyed sort of reading through your publications and the peer-reviewed literature, and I think about almost about 20 years ago now, you started publishing on how you rediscovered the house call, sort of this concept of, oh, okay, I thought that was something for more for sort of the mid 20th century that we sort of forgot about. But you mentioned there was I think the first paper was in 2006 in the Annals of Family Medicine. It was a home care, a key to the future of family medicine, where you talked about you needed to find, and you found satisfaction, but you found a sense of purpose that traditional medicine just didn't give you. Say a couple words more about this, because I think this is a really fascinating piece, and we'll be getting into sort of technology in a little bit and sort of the whole aging in place concept, but talk about a couple of the things that you found along the way as you rediscovered the house call.
Yeah, I mean, if you go back like 15, 17 years when I was kind of getting my start in medicine in terms of being done with my training, being sort of let loose on society as a practitioner, um, the notion about home care in terms of in medical home care, the physician role in home care, it was basically thought of as like something from a bygone era, like a vestige of the past. Some folks would mention me, oh, Steve, you're interested in home care. That's kind of like Marcus Welby, and I'd say at the time I didn't even know who Marcus Welby was, and so it had this nostalgia about it, but wasn't necessarily seen as relevant. But what I was experiencing when I was doing these home visits, and by the way, there was almost nobody else doing this in our
Yeah.
community at the time. It was an underrepresented service. There was a lot of families in need, but not a lot of options. But when I was going out and seeing folks, I was struck because my training really didn't involve a lot of home care. It was just medical training. It's in the hospital. It's in the some a little bit in the clinic sometimes, but um, I was just struck by the unbelievable amount of information you learn about people, just practical things like how they're managing their medicines, how they're dealing with managing their chronic illnesses and chronic conditions in their home environment, the state of the caregiver and how they're handling things. And then also just the appreciation and the gratitude.
Hmm.
It's really an act of humility to sort of leave your turf and go out and see people on their own in their own places. It's a gesture of kindness and compassion, especially if somebody is like, a lot of the people that need this type of service, late stage Alzheimer's disease or other neurological conditions or severe heart and lung disease, and makes it hard for them to get out to go to the doctor. And so, there's an aspect of, just showing people that they're worth being known and cared for and that they matter.
Hmm.
But a lot of practical medical stuff, like in terms of what you see. And so, I kept thinking as I would do more of this, I was like, I don't know how this is part of the past. I mean, this is when you think about all the issues that our health system's facing, the rising cost of care, and aging population, issues in equity and health disparities, managing chronic illness outside of the hospital rather than people getting, frequently rehospitalized. I said, this has to be part of the future. And so I spent a lot of my career writing about and trying to understand what those opportunities are and studying and advocating for an enhanced role of home care. I got to say now, 15 years later, and really, I don't think mainly because of me, but it's a much more contemporary topic. Like
Yeah.
if you look at you know the various blogs and consultancies and strategists advising healthcare institutions or governments, there's definitely an increasing chorus calling for new types of home and community-based care, innovation in home and community-based care, using home care for everything from post-acute rehabilitation to ongoing long-term care to acute care or hospital at home type of models. And it's been exciting to see that pivot. And I feel proud to have played a small part in that discussion, because I think that it's truly, it's one of the few win-wins,
Hmm.
where that we have in health policy and in strategy, where most people with chronic illness, aging, they want to be able to be in their home or home-like environments, or in the community. There's not a lot of people saying, I want to spend half my life in and out of hospitals and
Right.
emergency rooms. And at the same time, it's more cost effective for our governments, for families, for society, if we can help and have a system that supports people in the community. So I'm very much in love with that topic and see it as a really important thing for us to be focused on, with the aging society and all the things that we're struggling with.
Hmm. And alongside that, you also and one of your papers. This one was from January 2013. in Cleveland Clinic Journal of Medicine, and this paper that you wrote was entitled "The Case for Connected Health at Home." And here, you start bringing in the themes not just of hey technology, but of everything else that has to go along with technology, such as regulations and reimbursement, and just a limitation. Is there a strong Wi-Fi, whatever the case may be. But nonetheless, you pointed out some very important things, and this is 10 years ago now. We have a lot of companies now, everything from small startups to some of the big names. We had some on the show, everyone from General Electric, Best Buy. A lot of people are realizing, look, there is a technological model here, as you were just saying, whether we call it the connected home, healthcare in the home, hospital in the home, aging in place, that is there, that's going to require a lot of this age tech. You were, 10 years ago thinking about it. Talk a little bit about the thoughts that, you were working at the time in terms of connected health.
Well, the experiences I was having with my colleagues was, obviously the incredible human impact of home visitation, and that
Right.
in that relationship, and like I said, the conveyance of compassion, and but out making home visits. And I'd had some colleagues say, oh, I used to do home visits back in my day, but I'd have to flip through the map with a flashlight to find the person's house in these dark winter mornings and what have you. And I'm thinking to myself, I hadn't done a home visit without GPS telling me where to go. And then some folks say, oh, it's hard, you're going to be out there, but they need you back at the office or the hospital. How are you going to stay in touch? And when I was making home visits, I always had, a mobile device at that point in time, and it was really no issue to stay in touch with anybody while out in the field doing home visits. And then, I was actually, when I was at Cleveland Clinic, I think I was probably the first person that would take the Epic EMR system that the clinic was using
Sure.
on a laptop into a person's home, and chart on that. And actually, I had a couple experiences when I was in the person's home completing their medical record on a laptop. And I would send, recommendations for the person. Maybe they needed to get a new medicine or a type of medical equipment, or further visits like nursing visits. And occasionally the person would get a call to set up whatever it was I recommended without me ever calling or writing anything down or faxing any orders or anything like that. And so I saw, and saw how, convenient this could be. And then, you start to see the use of different types of telehealth and monitoring systems, and whether that's to try to provide alerts for when people fall, and to make sure that you can rally support for issues around elder mobility, or trying to get people home that had heart or lung disease in the hospital, and being able to monitor things like their blood pressure and
Mhm.
pulse rate and oxygen saturation and symptom scores. And so definitely was starting to see that not only was the human and the medical and healthcare assessment opportunity provided by home care very powerful, but this was going to get a lot easier and a lot more powerful because of the emergence of technology. Now, I will say, if you'd have told me a decade ago where we are now, I wouldn't have believed it. I would have thought we would have made more progress in terms of the role of um, virtual care and services into the home, the role of monitoring and smart home concepts supporting aging in place. And so the progress is happening. I mean, the pandemic was certainly an unwanted accelerant, but and I think it's inevitable. I mean, I think it's inevitable that in some respects, all healthcare is going to be home care, and that home care is going to be driven less through the front door and more through mobile and digital technology, um, and it'll be sort of a care anywhere model. I think that march is happening. Again, I would have thought that it would have happened faster than it has. But the the direction to me seems pretty clear.
Excellent. Excellent. So then we now arrive at Hebrew SeniorLife, and I've had the honor of having Sharon Inouye from the Marcus Institute of Aging Research on the show, talking about things like delirium and palliative care. Um, Now I'm talking the president and CEO. Would love to get, your overview, because obviously it's a sort of a broad mission statement. You're not just, involved in creating these senior living communities, but a range of really high tech things, from personalized healthcare to aging research to obviously teaching and educating this next generation. Take a little time to sort of walk us through, because that is we're over 100-year history now. I was unaware of that until I sort of did my research again on the organization. Take us a little into the history of the organization and a little bit of what it's all about today.
Absolutely. Well, I'm 4 months on the job as the new CEO, and I've been fortunate to have a great team, a great predecessor in Lou Wolf, and board help me get up to speed, because it's been, a lot personally, just to learn the ropes and to start to build those, important relationships, so I can be a good and effective leader for the future. But Hebrew SeniorLife is a Harvard Medical School affiliate. We're based in Boston and serve the greater Boston area and provide an array of elder services, from housing, affordable housing, also somewhat expensive, but very amenity-rich life plan communities, long-term care hospital services, a very unique model for long-term care for the most seriously ill and seriously impacted older adults that need an intensive long-term care model. And then a whole range of other outpatient medical services, home and community-based services. And then within that, and on top of all that, the organization is one of the global leaders in aging research, publishing 20 to 30 peer-reviewed scientific articles in aging topics every month, millions of dollars in NIH funding and other forms of funding to advance aging research through the Marcus Institute for Aging Research. And then it's a rich venue for teaching and training, physicians in training, nursing education, and a broad range of other professionals that we're committed to training. So this is, in my view, a national treasure type of organization. This is one of the true centers of excellence in aging, and that's why I wanted to be a part of it. And so I'm just so proud to get to join the group and help the team figure out what's the next best way to make a difference.
Mm-hmm. And as part of that, I was very interested to read about what the organization calls the Vitalized 360 initiative, which is quite interesting, because, as you were just mentioning, it is a rather unique, all-inclusive ecosystem of really everything that goes into healthy aging, not just health and fitness, which we spend a lot of time on, but everything from the principle of lifelong learning and sort of this education for the sort of the third generate, whatever they typically call it now, spirituality, loneliness and connection, all these things we're finding out about. Loneliness may be as bad as smoking multiple packs of cigarettes. Aging is many things. Talk a little bit about what Vitalized 360 is all about.
Yeah, so Vitalized 360 is one of the initiatives within Hebrew SeniorLife that's focused on optimizing people's health and their chance at living their best lives in a housing community, okay, in a senior living community. So actually, Vitalized 360 is one initiative that's been successful and that we're advancing, and another one's called R3. And these models they're one of the things that I really was excited about getting to learn more about as I joined Hebrew SeniorLife, because the idea is that if we support people to live their best lives and to live as healthy as possible life in housing in the community, then they can potentially avoid the suffering and unnecessary costs of hospitalization and needing higher levels of sort of institutional care. So we think about Vitalized 360. This is a model really focused on helping define for elders what matters most. Okay, so this involves assessment, holistic assessment about various aspects of their health, mobility, their mental and psychological state, their personal priorities, preferences, and values, and trying to tease out what matters most to a person as they age. And then using wellness coaching, the coach and the elder work on developing a plan, and also following up and seeing that the plan is being followed and modified over time. And so unlike the typical care plans that I as a physician might write, that say take 2 pills and call me if it's not working type of thing, these plans involve things like they might involve issues around supporting exercise and mobility because of the desire to remain more independent, or they might involve things that support a person's aspiration to be more artistic or creative because that's what they want to be a part of their life, or they might involve finding ways to help somebody get more in touch with their spirituality in some way, because at the stage of life that they're in, those are the issues that are important for their well-being. So Vitalized 360, it's a model in senior living. It's about identifying what matters most and trying to support elders in that type of plan. And then, that R3 model that I mentioned, that's been really focused on, right care, right place, right time model. That has been a model we've deployed particularly well in affordable supportive housing communities. And this has involved wellness coordinators, wellness nurses, and it's addresses individual goals and priorities. Like Vitalized 360 has a bit more of a medical component to it in terms of chronic illness management, preventive health services like screenings, vaccinations, support, and care coordination. And so, and the R3 model actually has now some health services research data to support that when implemented in affordable supportive housing communities, that the people's trajectory of care is better in terms of lower hospitalization rates and less hospital days than in communities that don't have that type of service. So, these are, if you go back personally, you'd ask me about my personal journey and about, how I got started. I had this deep interest in what are the right things that are going to support people living in the community, whether it's in their private homes or in, senior living communities. What are the things that are going to help them have the best quality of life, and their families have the best quality of life? And also, what are the things that are going to be value creating for society when we have, nearly 20% of our gross domestic product as a country going to healthcare services, the Medicare spend growing proportion of the federal budget, important to make good on those promises to our elders that have paid into those systems, and at the same time make sure that these are value creating services that also don't crowd out other societal priorities.
Mm-hmm. Mm-hmm. And as we go a little bit now into the innovation and the R&D, obviously a major cornerstone of that is the Marcus Institute for Aging Research within Hebrew SeniorLife. And as mentioned, Sharon's been on the show talking about these innovative protocols in the area of delirium. A lot going on there in terms of things you've been involved in terms of Alzheimer's, dementia, interesting work in cortical plasticity, and then sort of a second major basket, which I'll just call frailty / sarcopenia. Talk a little bit about the Marcus Institute within Hebrew SeniorLife, because it's been, as I mentioned, you've been thinking about these issues for a while and working on them sort of long before, geroscience was a thing. Take us into the Marcus Institute a bit, if you would.
The Marcus Institute for Aging Research is an incredible team of scientists that is focused on aging, okay, and trying to identify cures and interventions for common conditions of aging that are causing mortality and morbidity, and also looking at ways, to prevent some of those problems in the first place. And this group, it is a diverse group. Both diverse in terms of the backgrounds and the personal experiences of the team, but also diverse in terms of the academic disciplines, that are involved. We have, people from medical backgrounds, engineering, nursing, other social science backgrounds that are involved in the Institute, and they're incredibly productive on a whole range of topics. And, as a geriatric medicine physician, one of the things that I'm familiar with, just to kind of pass your board exams as a geriatric medicine physician, some of the principles that Marcus Institute investigators like Sharon Inouye, who you talked about, or like our director, our chief of our institute, Lou Lipsitz, have identified. You've got to know the themes and ideas that they've developed in their careers just to pass your board exams. That's the type of significance that this institute has had on the practice of geriatrics, and the breadth of work happening. It is just incredible, and actually, I'll probably be a disappointing, disappointing person to have on the show here in terms of my ability to get into the depth of all the work being done. But when I look at the breadth of it, I'm just blown away. We have, of course, you highlighted the work of Sharon Inouye. We have incredible work being done across issues like sleep health for older adults with Amir Baniasati, looking at the role of antioxidants and cognitive health and aging with Courtney Millar. We've got Brad Manor and the focus on gait mobility issues, Day Kim's work on frailty and frailty assessment, and of course the lifetime of contributions of Lou Lipsitz. It's amazing, and I'm just scratching the surface in terms of what we're discussing, and I see, my role in this is to keep finding resources and talent to make sure that this group can succeed.
No, it's obviously, you're the head of it all now, and so no, it's awesome that you have and major responsibility to think about all of these things, and what takes priority and so forth. But it is an amazing portfolio, and glad to do more follow-up episodes in these respective silos, let's say, of research. I just have to ask you, get your perspective on one of the things, Steve, while we're on sort of the theme of research and innovation, because one other area that, and I guess this sort of falls into the bucket of the gerosciences. I think that's the hot term for it nowadays. But one of the things I was reading about was this really interesting work that was going on at Hebrew SeniorLife on studying the biomarkers and the genetics of aging and age-related disease. And of course, this goes in a couple different directions, right? We could, create interesting personalized therapies and understand sort of what makes us age and health, health span improvements. It also, hits on something else, longevity and that whole area of the industry. What's your perspective on all this? I'd just like to get your thoughts on sort of where this is all going, and then, from your own, work with these seniors, do they like being, sort of I wouldn't call it the guinea pig, but sort of like donating their data, if I'm a healthy 90-year-old, what gets me there, how can my genetics help sort of inform the next generation of geroscience drug development? Love to hear your perspective on these topics.
Yeah, no, absolutely. I mean, just as a setting aside my role here as a leader for Hebrew SeniorLife and as a geriatrician, as an aging human, I'm very interested in the subject of innovation and longevity, and opportunities to live healthier and more vibrant lives as we age. And obviously the fields, the various associated fields are blossoming in terms of the emergence of an understanding of the our genome and various genetic factors that impact how we age, and just a broader understanding of the levers that impact human health. I think we're complex beings, right? The human health is driven by a complex cocktail of both genetic, physiological, environmental, and psychosocial factors. And what I love about the Marcus Institute and our efforts is that we really are focused on the holistic opportunities across those different areas. I think that the promise that we might identify new drugs and new therapies in aging that hopefully address some of the issues that have faced people as they age, whether that be cardiovascular disease and the morbidity and mortality associated with cardiovascular disease, and musculoskeletal issues, and of course brain health and cognitive cognitive issues. I think is incredibly exciting. I continue to be on the lookout for things that have current day clinical relevance and clinical practice. I do keep coming back to that in terms of the health of our current residents, families, to mobility, the good nutrition, and focusing on what matters most, and having a healthy mindset, and keeping our minds in a healthy spot seem to be some of the most important issues, irrespective of the cards we were dealt in terms of our genome. But no doubt, maybe the mythical fountain of youth is upon us with the modern bioscience. And right now I tell people the best fountain of youth that I see is the fitness center.
Yeah.
But there's definitely a lot of promising developments.
Absolutely. Yeah, absolutely. It's nice to see, you thinking about, all these aspects. See, one last thing I have to ask about, and it's kind of, it's a shame that in sort of 2024 we even have this, to think about this, but Hebrew SeniorLife operates this really unique Center for Prevention of Elder Abuse and Neglect. I think it's probably the only one in Massachusetts, but say a couple words about this, if you would, because the concept of requiring these safe shelters and, to prevent abuse, neglect, financial exploitation. I mean, it's just a shame as humans that we have to have something like that exist. But say a few words about this part of your organization. I think it's important.
Thank you so much for bringing up the topic. It is a sad reality, but elder abuse and neglect are much more common than we want to imagine. And because of some of these chronic conditions, sensory deficits, vision, hearing, aging syndromes that involve brain health, it's not been uncommon that people either are taken advantage of, or abused, or exploited. And then also we have issues of self-neglect. And this set of issues, it's the ugly underbelly of aging in America. And at Hebrew SeniorLife, one of the things that we're proud of is to play a role in trying to be a solution through our center to prevent elder abuse and neglect, offering some emergency shelter for people that are in abusive or unsafe circumstances. Also, we're doing community outreach and case management with certain families and individuals who are been identified as victims of abuse and neglect. But this is an incredibly important topic, if we're going to have a compassionate and just society to age in that we address. And we need we need a lot of solutions. And so we're playing a role. Certainly, the various organizations funded by the Older Americans Act and area agencies on aging are playing a role. And the whole cadre of small but mighty cadre of elder advocates, attorneys that are playing a role. It's something that just shouldn't happen, as you said.
Well, again, I'm glad I'm not glad it happens, but I'm glad that you have a structured system to deal with it in the Massachusetts and Boston area. So it's just another piece of the puzzle I wanted to highlight there. And it's an extremely impressive portfolio. I know you only been there for a few months now, but I'm going to look forward to continue to follow you, Steve, and everything that is going to be happening. While we have you, we're almost to 2024 now. Anything coming up as we enter 2024 in terms of conferences, public-facing initiatives, things that I missed or that we should know about while we have you today? Please take the floor.
Thanks, Ira. Well, it's been a pleasure to speak with you. I'd say, the thing to really be on the lookout for, if you're concerned about issues of aging and improving the aging experience, that we didn't touch on, would be to also look at issues of caregiving in the workforce, nursing, frontline caregivers. We're hoping at Hebrew SeniorLife to launch some new initiatives around advancing the workforce and expanding the workforce, because we need more caregivers. Our demographics are just not great, and we need focused effort on developing these frontline folks to support aging. And in terms of upcoming meetings, presentations, I'll have to circulate something back to you. I don't have any dates at the tip of my tongue, but the field is exciting, and there's a lot of work happening. I'd certainly stay. If you're interested in aging-related issues, stay on the Hebrew SeniorLife listserv, in the Marcus Institute email lists, and there's a lot of communications, blogs, and updates around topics of aging research.
Mm-hmm. And we will put all links in the bio of the show, so people can check out everything that we've been talking about. I appreciate that you brought up the issue with sort of the frontline care workers and sort of this whole, I guess, related theme of sort of the unpaid caregivers that are out there that we don't normally think about.
Just family caregivers,
friends and family as well,
neighbors,
that are an important
family,
part of this. So
friends, the huge issues. It's worth diving into in more depth, maybe the next time we speak, because that is an incredibly important topic for our society overall.
Absolutely. Really, really outstanding work, Stephen. I'll definitely take you up on doing a follow-up episode as you continue to further immerse yourself in the organization and build up these various initiatives. Again, for everybody that's going to be listening to this episode of our show across the various podcast networks or watching on our YouTube channel, again, you spending time with Dr. Stephen Landers, President and Chief Executive Officer, Hebrew SeniorLife. Stephen, I want to thank you again for taking the time out of your schedule to come talk to us for a little while. Obviously, thank you for what you do. And as we like to say here on our show, thanks for helping to create a better tomorrow via what you do. A really great story,
Thank you.
And look forward to your journey.
Be well.